At this point, I'd like to welcome everybody to our webinar, Aortic Imaging, Your Questions Answered, where we're going to get a short presentation from our speaker and then get to all your incredible questions. My name is Eileen Michelli, and I'm the Chief Program Officer for the Foundation. And I'm really glad to bring this all to you tonight. We have a Q&A box here. Look at the difference between the Q&A and the chat. Put your questions in the Q&A box because that's where we'll go after the presentation. And hopefully you can hold your questions until Dr. Polsani is done, because maybe he will be answering your questions while he's talking. So after the presentation, questions go in the Q&A box. Helene, my amazing colleague, will be in the chat, and she'll be sharing some links throughout that will be helpful to kind of supplement what you're hearing tonight and point you to other resources that we have. So tonight we're featuring Dr. Venkat Philsani from Piedmont Heart Institute in Atlanta. We're thrilled to welcome Dr. Polsani and his colleagues at Piedmont as a sponsor of our Atlanta Walk for Victory, which is coming up later this spring. And before I introduce Dr. Polsani, I'd like to welcome our President and CEO, Michael Weimer, to say a few words. Michael.
Thanks, Eileen. Good evening, everyone. It's always actually a pleasure to be here and see a number of our old friends, and also welcome new people to the foundation activities. Lots of things going on. I'm excited about tonight because I don't remember a presentation on aortic imaging anytime recently, for sure. And the fact that we had over 300 people that signed up for this is great. And Dr. Polsani is a rock star at what he does. And it's always nice to be in the company of great physicians. So we welcome you this evening. Many great things going on. Our annual conference is coming up July 8th through 11. I'm sure Eileen will talk about that, but it will be virtual. So it will be available not only here in the United States, but throughout the world as well. When we did our E3 conference back in the fall, we had 75 countries participating, over 3,000 people. So again, watch for announcements on the foundation website. I also heard, by the way, I think we have over 270 people registered for the walk that our friends at Piedmont are co-sponsoring. So that's terrific as well. And with that, I think I'm just going to sit back and enjoy the evening, and I'll be in the chat box if anybody would like to ask any questions about the foundation. And I think I'm thinner than that picture, Eileen. So we got to fix that picture.
Get me a new picture. I'm happy to change it out.
I need a new picture. I've gotten a little thinner, I think.
All right, get on.
Anyhow, this is great. I won't take any more time. Enjoy your evening. It's an honor to be here.
Great, thanks, Michael. So tonight it gives me a great pleasure to introduce you all to Dr. Venkat Polsani. He's the Chief of Cardiovascular Imaging Center of Excellence for Piedmont Healthcare and the Director of Cardiovascular MRI and CTA for Piedmont Heart Institute. And he will tell us later about MRI and CTA for sure. His research interests are in cardiovascular MRI, cardiac CTA, and 3D echocardiography, and their specific applications in valvular heart disease, coronary artery disease, and infiltrative cardiomyopathies. Prior to joining Piedmont Heart, Dr. Polsani completed a multi-modality cardiovascular imaging fellowship with level 3 training in cardiac MRI, echocardiography, and level 2 training in cardiac CTA and nuclear cardiology at Methodist DeBakey Heart and Vascular Center in Houston. So if you hear DeBakey and Houston, you know that he was in the right place. And just a little bit more in case that's not enough, Dr. Polsani earned his medical degree from Gandhi Medical College in India, and then completed his internal medicine residency at Abington Memorial Hospital in Pennsylvania. He did 2 years of research fellowship in atherosclerosis and vascular medicine at Baylor in Houston, and a cardiovascular fellowship at Tulane. I was really fortunate to get a preview of this presentation tonight, and really excited that we'll be bringing this all to you. So with that, I'm going to give the remote control to Dr. Polsani. Oh, first I have to stop sharing, and then I can give you the remote control. Can you get the remote control there now? Share your screen. There you go.
Can you see my screen now?
Yep, just slideshow from the beginning and you're all set.
All right.
I will shut off my video too.
Yeah. Thank you, everyone. Thank you for joining. And I would like to thank the Marfan Foundation for giving me an opportunity to present on cardiovascular imaging, especially vascular imaging, which is very important in patients with Marfan's and vascular disease. So with that, I just want to get into the main presentation here. Basically, the goals of the presentation are to kind of give you an aortic anatomy, basic aortic anatomy. What are the available techniques for imaging aorta, images of aorta by different techniques, and measurements, how it's done on different techniques, and what are the current recommendations for aorta imaging. And I won't dwell into the aortic surgery. Obviously, it's not my subspecialty, but what is seen on imaging that leads to surgery, I'll show a few. And I'll end by two case examples. One is somebody who is young, who's for serial follow-up, and the other case is somebody who has a disease process. So with that, what are the techniques that are out there for imaging of aorta? Ultrasound is one, and CT is one, which is a radiation-based technology, and magnetic resonance imaging, different physical aspects that are used for imaging of human tissue, basically. This is a cartoon showing different areas of the aorta that everybody is interested in knowing. The part that's connected to the heart, the sinus, is called basically sinus of Valsalva, and it kind of dives into this area called sinotubular junction. Then you have the ascending aorta, arch, descending thoracic aorta, and the abdominal aorta, basically. The component that we're very keenly interested are the ascending aorta and the aortic sinus of Valsalva. This cartoon also shows the blue lines, basically reflecting where the measurements of the aorta are standardized and are done repeatedly when in repeat scanning. You can see where sinuses are, that measurement is done. Ascending aorta at isthmus of the arch, and also at the level of the diaphragm. With that, the other thing to remember is there are different techniques available. Each has its strengths and weaknesses. So which to use when becomes very important. Obviously, TTE stands for a transthoracic echo. Very easy to use, portable, and its reliability is an issue because reproducibility of image, as I'll show you images coming down, is kind of different. The spatial resolution is on the lower side. TOE stands for transesophageal echo. It's nothing but it's echocardiography, but it's an invasive echocardiography where you're putting the probe in somebody's feeding tube and taking pictures of the heart from behind through the feeding tube. So that's an invasive way of imaging the aorta. CT is another technique, and MRI. Basically, in terms of spatial resolution, in the sense that how well you can look at the structure, CT trumps. In terms of moving structure that can be seen, transthoracic echo, ultrasound, and MRI are good at that. CT is a radiation-based technology, but remember one thing, things are changing with radiation. We are not using as much radiation we used in the past for imaging of the aorta like before. And CT and MRI obviously use contrast too. And remember, the contrast has nephrotoxicity, but it doesn't affect everybody. CT contrast has iodine in it, and MRI contrast has gadolinium in it. And even the indications for patients with renal problems are changing. We could use MRI contrast if needed now. And the cost, obviously, I won't get into it. It's variable in different countries when used. I'll go to the next slide here. So here, this is where the most important part of the presentation is. I just want to share images and go over what I'm looking at. So these are echocardiography images on patients, on someone where we're trying to measure the root. And this is a typical image that we use for measurement of the root of the aorta. We measure the root like this, in a view that's gotten through the surface probe. And you can see the tissue as we go through the images. Remember the spatial resolution in the sense that how well the structures are differentiated from each other. And the same thing done by transesophageal echo is on the right side, where the probe is in somebody's feeding tube, esophagus, and we're taking pictures of their aortic valve here, like 3 cusps of the aortic valve, and the root of the aorta, and that can be measured out like this. And this becomes an important tool in diagnosing if somebody has dissection and acutely, and you want to look at it, we use transesophageal echo. if CT is not available immediately. Then the next technique I want to show are images of thoracic aorta, but remember how the tissue is looking here. This is a non-contrast CT. So there is no contrast that we have administered externally. The contrast you're getting between the tissues are because of differences in the tissues itself. Like this black area is air, and this grayish area is tissue. And the thing I've measured is the aorta. Very frequently, this may be one test that somebody gets for evaluation of lungs or something else, and they find out they have an aneurysm. So this becomes like almost like after an echo, a screening test done for something else, and serendipitously they find their aorta is kind of enlarged, and then they get a contrast study after this. And how does a contrast study look? This is how it looks, and I'm showing you images here of the aortic root, in the sense that where level of the aortic valve right above it. And how do we measure the aortic root by different techniques? On the left panel are two different kinds of measurements. These are standardized methods. One on top is what I usually use, but one at the bottom is also used by physicians who repeatedly measure. As long as the technique of measurement is the same every time somebody gets scanned, it's reliable. On a CT, you can see how well, when you give contrast, you can differentiate between one area of the aorta versus the heart and versus where the contrast is not there. And on the right panel here, you have the valve opened. You can see that here in this image here where my arrow is pointing, the valve is open. Sometimes we measure with the valve closed is the technique most people follow, but some institutions follow when they measure using the valve open. There are slight differences, not a huge difference in measurements when this is done. But as long as the repeated methods of measurements are the same, it's fine. This is an important point I want to make. How is an ascending aorta right above the root is measured? On the left here is a normal technique that's used very often, where you measure the aorta where the pulmonary artery, that's the artery that supplies blood to your lungs, divides. And what is being done, you can see here in these two images, I'm not perpendicular to the aorta, but I'm measuring here. So you may get a different measurement on the same patient when I measure like this versus here, where I'm perpendicular to the aorta in the left and this panel here. So this is a very reliable method, reproducible method to use a double oblique technique of measuring the ascending aorta. I use this, and I think this is a more reliable and reproducible technique, because this technique is often used, but it will lead to each person may measure at a different level, rather than measuring at a level where you think that there is the thickest area of the aorta. The other image I want to share here is how does a dissection look on CT. So this is basically what we call a snake view of the whole of the aorta. On the top is the root. As you come down, you see the arch, and this is the thoracic descending aorta, and this is the abdominal aorta. This dissection here that is repaired, you can see by dental surgery, this portion ascending aorta is repaired, but there is a residual dissection. That dark area here in the middle is the flap from the dissection. And that separates what we call the true lumen, which is small, which has less contrast, you can see. And on the right side, which has a lot of contrast, that's the false lumen. So that's how a dissection looks on CT. And one important point, if you take anything from this presentation, is this is probably the most important point. A lot of times the scans are done without gating. What do I mean by that? So think of it, when you're in a CT scanner, you can move, that can affect the heart motion. You can breathe while they're scanning, that can affect the heart motion. And heart rhythm is very important. If your image is not synchronized with the heart rhythm, you can get an image that looks on the left side. You can see there is a line here that should not be there. On the same patient, when scanned with gating, you can see that line is gone. So always ask if your aorta is being imaged, especially thoracic, not the abdominal aorta. If all you're getting is imaging for the thoracic aorta, make sure you're getting a chest aorta, portion of the aorta, that it's a gated image, because that's a very reliable image that you can measure every time you get a scan, and it prevents artifacts. And as a patient, the best thing you can do is cooperate in terms of not moving while a scan is acquired and not breathing, holding your breath. That really helps, especially with the chest portion of the aorta imaging. How does it dissect? How is it done on MRI, which is MRA? MRA is a form of MRI, but it's just magnetic resonance angiography, where you give contrast and you can basically image the aortic root, like here, and the measurements are done this way. You can already see a little difference here. There is a little bit of less resolution going from one tissue to the other. So you can tell that CT has better spatial resolution than MRA, definitely. What advantage of MRA is like this valve that's opening and closing. You can see that really well in MRA because this image can be acquired. The good news is, there's no radiation here, less radiation. If you were to acquire this a moving image of the valve like this on CT, you will end up giving a lot of radiation. But the spatial resolution is in the sense that the resolution of the image is slightly low. So one important thing about MRA, what are the advantages? You can have natural tissue resolution in the sense that this is an example of a aorta imaging that is done by MRA without giving contrast, without giving radiation, and no IV. So this patient of mine who walks in, who basically gets serial follow-up imaging, they just come in, they get this image, and they go home. There is no IV, no radiation, no contrast. So the MRA is very good if this technique is used for gating with good breath holds. You can get this image on some patients. So in someone who is young with serial follow-up imaging, you may imagine this would be a good technique to use. The next one is a contrast-enhanced MR angiogram, where you can see what ends up happening is here, the same MRA angiogram of the thoracic aorta is done with contrast that's given to the patient. And you acquire the images of the aorta with the contrast. And you can acquire multiple images with MRA because there is no radiation. You can keep acquiring images multiple times to get more images of the aorta or the other vascular structures within the chest. And this is an example of a gated MRA where we acquire just the aorta. You can see there is an aneurysm in the ascending aorta that can be shown. So gating technique can be used when you want high resolution imaging with MRA. How does dissection look by MRI? So this is an example on the left side top. You see this cartoon with blood flowing through, and you're acquiring this angiogram multiple times. And this dark line here going through is the dissection. And you can see the true lumen in the sense that the normal aortic tissue fills in first, and then the flap on the other side fills in after the false lumen. And these are all the angiograms you can acquire, about 30 of them in about a minute and a half. And you can combine all those. The good thing about this is it tells you how the blood is flowing from one part to the other and where things may be going wrong. This is a similar example of a dissection by MRA imaging. And this is, as I said, a cinematic image where you get a cine of not only the heart, but also you can see the dissection in the back. And here too, there is a dissection. This thing that's moving in the aorta is the flap. That's the portion that is torn, and that's kind of flapping. It's called the flap, intimal flap. That's what it's called. The one side is the true lumen and the other side is the false lumen. And mobility of it tells us how chronic a dissection is sometimes. And that's the same thing here you can see in the descending aorta. So in a way, this kind of should give you an idea of like the different images I've shown you, gives you an idea that all three techniques can be used. When do you use what technique depends on what we're trying to do. If it's a serial follow-up imaging on a patient, we want to use less radiation, no contrast if possible, and we want to get good imaging, I use MRA. If we are using it for the first time, you want the best accurate measurements, I use CT. And transthoracic echo obviously is the basic screening test. That's how somebody is having a heart screening for some other reason, and that's when we find out the root may be slightly enlarged on the echo. And even as you saw the images, you saw in the echo images that you don't see all of the aorta on the echo images. You miss the arch, you miss proximal portion of the descending aorta to a large extent. But on CT and MRA, you can see all of the thoracic aorta in the image. So the choice also depends on what portion of the aorta you're imaging. You want to know the root, you always can measure is using the transthoracic echo, but the reproducibility will be less of those findings. But if you want to image whole of the aorta, you probably want to image majority using a CT or MRA. With that, I want to share a quick example of a case, how I follow up on a patient we have scanned here. Let's see if I can share the images on this patient. This is a patient that has Marfan's, and we have scanned her.
We're not seeing it yet.
You're not seeing the screen
No,
here?
I think no, you may have to pick that screen to share.
1 second.
Yep.
You share. Can you see now?
Yep, you're good now.
Okay, good. So this is a young patient who is about 30 years old, has known diagnosis of Marfan's, and we have been, she gets a yearly scanning of her thoracic aorta. So what we have done is in her, the first time she came around, we did a complete MR angiogram. The angiogram helps you not only image the valve itself, and you can see, patients with Marfan's tend to have other abnormalities in the heart too, not just you can have the root, but you can see here, this is called the mitral valve, which you can see here, kind of playing a little slow. That can have prolapse too in this patient, and then she has it, and that we can see. And at the same time, the first time she came for her imaging, we did a contrast enhanced MRA to completely measure her aorta, not only the root, ascending, arch, descending, and the abdominal aorta completely. And we not only did that, we got a complete heart function analysis on her, all of her imaging, and we used the cine imaging to measure the root sometimes too. And then her repeat imaging, when she came back a year later, we scanned her without contrast because we assessed her heart function quickly, and her valve, you can see this valve here is a mitral valve that's a little leaky, and you can, that has prolapse. What does it mean is the valve is kind of falling back into one of the chambers. It should not. And the repeat angiogram we performed using without contrast, no IV. So now for the last 3 years, she has been getting imaging this way. This is how we follow her, basically. She's 30, she doesn't want IV, she doesn't want radiation. So we have been doing non-contrast MRA on her and follow her regularly. And it gives good, this technique gives good information. But there are cases where I'll have to go back to my presentation here to share that. 1 second. Where there is an extreme scenario when the patient comes in and the first thing you see is a very enlarged heart like this. And the root, this is actually the root of the patient that's very enlarged, you can see. And the valve that's supporting that root is the aortic valve. And see this aortic valve is almost looks like a Mercedes-Benz sign. When it closes, it is actually leaking. It doesn't close all the way because the root is so enlarged. So the person has what we call valve regurgitation. The valve is leaky along with the enlargement of the root, and all of the blood is going back into the ventricle. This is one of the complications that happens when the root enlarges due to Marfan, is you may develop what we call aortic regurgitation, which some of you may have heard of. And this technique we have used here is to image is MRI. We not only assess the heart dimensions, function, we also assess the dimensions of the root, and we also assessed how severe is that valve leaky before any procedure is done. So all of the surgical planning can be done using this technique here, where we measured the dimensions of the heart, we measured how leaky that valve is using one technique here, and we measured the dimensions of the root. That's the root. This is the left ventricle. Actually, I put a cartoon here. The enlarged root is right here. So basically, all the planning for surgery is done right away using this technique. It all depends on what we are trying to achieve when it comes to serial follow-up imaging, or is this an acute situation where we have to get all one test before the surgical planning, anything that's planned. Depends on that. And even a dissection too, what we're trying to achieve. If the kidney function is affected, we may use a transesophageal echo. If kidney function is fine, we could CT is the first line of test for dissection, if you ask me. What are the recommendations for imaging of the aorta? So these are the main things that to remember. You know, diameters are measured of the root and the aorta at pre-specified site. In the first cartoon, I kind of showed you all like way to measure root, ascending aorta, arch, and the pre-specified points where we measure. Every time you measure, you want to use the same methodology for measuring. And if it is all redundant, the segmentation of the aorta, they should be reported the same way every time. And obviously you have to keep in mind that pregnancy, renal function, allergy to the contrast before you acquire images. And if somebody is getting repeated imaging, you need to decrease radiation. Having said that, remember the techniques of CT have gotten so better, radiation dose is very low nowadays with scanning. And with that, I will stop. And these are the recommendations for surgery. I won't dwell into the depth of this, but obviously, you know, 4.5 centimeters for Marfans with risk factors, and you know, the risk factors being family history of dissection, and also obviously sudden yearly increase in size of the aneurysm. Eileen?
Great, thank you so much. I was just busy reading that slide.
I can leave it there if anybody wants to read. Sorry.
That's okay. Well, that's good. Let's go back to just us. Let's stop sharing, and this way they can see us while you're talking basically about these questions. So, if you want to stop share there.
Yep. Mm-hmm.
And I just want to invite people. Thank you so much for all the great information and those actual images. I think that's what people really want to see, and look at while they're getting getting the descriptions. And so I see some people have some questions that they've put in the Q&A. If anybody else has any more, put them in the Q&A rather than the chat. And I'm just going to go right to these questions that were pre-submitted. They were pretty much in a few different categories. Your guys are asking about frequency, which test, questions about the findings, a couple of questions about some wording. I'm going to go to a couple of the miscellaneous questions because I know you talked so much about the actual tests. But you know, from a bird's eye view, what specifically is most important on the results that someone with Marfan or a connective tissue condition should pay attention to?
I think the most important thing is obviously the dimensions of the aortic root and the ascending aorta and the aneurysm site, where it is, and how are the measurements done. matter and what technique was used for acquiring the image. If the first time test was an echocardiogram that screened, I would always get a CT followed by that to kind of measure the true measurements of the root and the ascending aorta. Those will become very important. And obviously the echo will show if there is any valve involvement is there at the same time.
And that goes to this other question, which is, who should be doing this? Does a surgeon recommend the technicians? You and I talked about this a little bit the other day, but can you say something about the reliability of who's doing those tests? Are they done the same by everybody?
Yeah, that's the big challenge. I don't think they're done. The quality of imaging matters in the situation for reproducibility, and you need to have a certain amount of advanced imaging training in this specific arena for you to know what we are looking for when you're imaging these patients. Because obviously some of the techniques of imaging are so subspecialized that acquiring those in a smaller center may be difficult, or even setting that sequence for acquiring the image may be a difficult situation. Or the plain truth is they may not have the equipment to do certain high level of advanced imaging at that point. So it should be somebody, right now in terms of physicians who do this, radiologists obviously are the main physicians who do it. But in a lot of the technique, you always have to ask for gated imaging of the thoracic aorta, in the sense that it always needs to be EKG gated when you're looking for your root measurement. And the second thing is the arena is changing where cardiovascular imaging is kind of very broadened now. Like, people like me who are being trained to do advanced vascular imaging and cardiac imaging are coming out and getting trained, extra years of training. These are the physicians I would say should be doing this imaging.
Great, thank you. Should patients request copies of their results, or is this not something patients should do?
I think they should, and they should also request the copies of their images. Mm-hmm. So what I do actually in patients I see in clinic, since I'm an imaging physician who is also a clinical cardiologist, I see the report, but I actually load all the images of the patient and review the images. Because for me, seeing images matters when I'm actually taking care of patients who I'm looking at. Because there is, as I said, it's a human nature to have some variability in measurements. But for me, I just want to compare it the way we measure in our institution. And if I were to get another set of imaging on that patient a year from now, then I clearly know what I measured versus what was done before, rather than comparing it to a report. Report is, it's one point in time, but images are forever.
Mm-hmm. Okay, great. And what, as you can tell from these questions, the people in our community are very educated about their condition. And now after hearing your presentation, they're really up on the whole imaging. What if they're looking at something and they see something suspicious? How do they bring that up to their doctor if the doctor doesn't mention it? Or, what's your recommendation for that?
Yeah, so most institutions have a process for this. So second opinion on the imaging they have acquired. So what happens is basically I would bring it up with the physician or within the institution, the imaging departments have a section where you can bring up this question and say, my study was done here and this portion was not reported on, or I see this, can I have a discussion with the physician about this, what their thoughts are. Very often they're benign findings that they are looking for, but it's a good idea to have, because the world has changed. The patients get the reports first before the physician discusses right now. So that kind of makes it tough. A lot of times the questions come back and before we keep kind of going back and forth about it. So yeah, mainly I think reaching out to the department.
Okay, great, thank you. So we're gonna go into some questions about which test. Lots of questions about which test. Pectus excavatum is a major finding in Marfan, the indented chest. Which test should somebody get? One doctor told this person that they should not get an echo and instead get a cardiac MRI. Does that interfere with testing? What's your recommendation? What have you seen?
So it depends on a lot of times. The first test, if it's a CT, you'll end up seeing the pectus, or the MRI, you end up seeing the pectus and the severity of pectus too. I've seen where the severity of pectus excavatum causing compression of the right ventricle, because that's the part of the heart that's right behind the sternum. And that can cause decreased blood flow through that area. And that MRI shows it really well. My first choice would be to do if you have significant pectus along with Marfan, to do a complete cardiac MRI as the first test. And then they can be followed in future if pectus is very small, it's not of any clinical significance. They can be followed with non-contrast imaging or echo in future.
Thank you. Somebody is saying they have an ascending aortic aneurysm of 4.8. Is having an echocardiogram enough, or should they have additional tests?
So they're having only echocardiogram? That's what it was measured on?
Is having an echocardiogram enough?
No, I don't think so. I think when your aneurysm is that big, the orthogonal measurements become very important. It may not be 4.8, it could be more. Always get a complete imaging of the thoracic aorta with a CT. I would do a CT first, or an MRA, complete MRA of the thoracic aorta, one or the other, depending on the patient's age. This is somebody who is, late 50s or 60s. You could do CT because radiation exposure from there on, the long-term effects are less. Somebody is very young, I would do an MRA.
Okay. So somebody without the aortic aneurysm and they're just being followed, should 2 or 3 different types of imaging be done? If not, which type gives the clearest picture of aneurysms in the ascending aorta before the arch?
I would do, I think the best techniques are CT and MR. If you're looking for an aneurysm and accurate reproducible measurements, depending on your threshold for radiation and whether radiation technology can be used or contrast needs to be used, the follow-up imaging is always using MRA or CTA, because echo can be used. If echo is negative and you have one CT or MR that's negative, the follow-up imaging could be echo. But if they have any changes that are worrisome, I would always follow with CT or MRA.
If somebody can't have an MRI, can the same information be gleaned from an echo and a CT?
Yes, from CT. So one thing about MRI I wanted to mention, I forgot, this is a very good question somebody asked, is there is the notion that they cannot have MRA because they have a defibrillator, or they have some metallic spine. Actually, on the patient I showed, there was some artifact from the metal. So most of the defibrillator devices nowadays are MR conditional. You can actually get a scan with MRA, even if you have a defibrillator or a pacemaker that's implanted in you. So I would add, so that's the other thing that comes down to, not all centers do it. That's the question you have to ask, where you're getting the scan, because centers of excellence, which depend on, which provide care for this kind of patients, always scan patients with MRA, even if they have a device. So the contraindication depends on where you're getting the scans to an extent, I think. So the alternate technique is CT or echo, yes.
Okay. You mentioned before about the radiation. Can you explain the risks associated with exposure to radiation?
So, repeat imaging with radiation, just living on Earth or traveling by flights everywhere, a natural background radiation we get every year is about 3 millisieverts of radiation. Mm-hmm. That's the amount of radiation we are all exposed to. A calcium CT scan, depending on the kind of scanner, we can get the radiation down to 1 millisievert. What ends up happening is radiation, if it's recurrent, and especially if the patients have other reasons they're getting radiation-based imaging or therapy, you have what we call stochastic effects. In future, not only radiation effects can cause cancer or risk of having cancer, they can affect the, I don't know if people remember the time when people had Hodgkin's lymphoma and they were exposed to mantle radiation. What that did was actually affected the heart tissue. And we see some of these patients with heart valve problems because they had significant exposure to radiation 20, 30 years ago now. But we are not using that amount of radiation anymore. So those are all the cumulative effects of radiation that can cause problems in the future.
Okay, great. Thank you for explaining that. One person says that the doctor says that their child has a Marfanoid physique. So they have the outward signs. What tests should be taken to confirm or rule out the aortic enlargement and possible Marfan?
I think it's a child, right?
Yes.
So yeah, some of the young children, they will not be unable to cooperate with MRI. CT is a very good technique on the first time if you do, or MRA too. Actually, if they're able to respond to commands, hold breath, and that kind of stuff. It's not very young kid. I would do an MRI as the first choice after an echo, basic echo.
Okay. Talking about kids a little bit, can you explain what a Z-score is?
Yeah, basically, I would. Z-score is based on basically the nomogram of the variation. The aorta is not mature enough; it's developing. So I deal with adult imaging, so I rarely, honestly, give Z-scores. But in pediatric world, it is used as a scale to kind of give. Okay, if you have this Z-score, it's because it's varying from kid to kid. It gives you an idea of it. Yeah.
I think we have it on our website. The Z-score about more information about how it's like the deviation from normal, depending on the body mass.
Body. So even in the adults, actually, that's a very good point you bring up. So even in the adults, the data for dissection, the data for surgery is based on absolute number. So we don't kind of index it to body surface area, except if they're very small or very large, very small in the sense if the BSAs are less than 1.5, we index it to their body surface area, and we use those numbers for future planning. Because the variation is very different from within the normal standard deviation that we deal with. So the change in that small person, it may be different from what we're dealing with in a regular person. So that's where the growing children, the Z-score becomes very important measurement because it's a variable number.
Great, thank you for explaining that. So just let's going over to frequency a little bit in this whole group of pre-submitted questions. Can you talk about, let's see, what should be the long-term routine surveillance imaging and the interval with somebody who's watching for ascending aortic enlargement, maybe looking at their root also? How regularly?
Yeah, so basically the first time you image a patient, after that, I usually image them a year later or earlier if there is significant family history of some dissection or something like that, and see the growth of the root. The growth of the root is less than 3 millimeters, or if it remains stable, yearly surveillance is okay. But if there is a rapid change in things, we have scanned patients within 6 months. Especially the change in dimensions is what matters. But think of this, though, this is where the question comes up, I think. Change in dimensions always should be gone back and compared with the original scan, because there is slight variability in measurements and between the same physician at different times or two different physicians doing measurements. So you have to go back and measure the previous scan and compare it absolutely to how it's going in terms of measurements. So I would say between 6 months to 12 months is most of our patients get repeat scanning.
What about older patients with connective tissue conditions? Somebody wrote that they're in their 70s. So somebody's made it that far. Maybe they've had surgery, maybe they haven't. This person doesn't really specify. But if you're later on 60s, 70s with a connective tissue condition, still yearly?
Yearly scanning, yes. Yearly scanning. And if somebody has dental surgery in the past and they're repeat imaging if it's without a dissection, If there is a dissection elsewhere, aneurysm elsewhere, we just follow by early imaging.
Okay. All right, I'm going to go to some of the questions now that were posted tonight. So if MRA is the main method of imaging, how often should contrast be used?
How often? Yeah, that's a very good question. It depends on the kind of person I'm scanning. If it's a young patient and the first time around I use contrast imaging and repeat imaging, young in the sense that, less than 40, repeat imaging is with non-contrast. If it's somebody above 40, the repeat imaging could be contrast. I think it's okay. And the amount of contrast we are using is very less too nowadays. And there is some question of MRI contrast. This is another thing to remember. It does not affect your kidney function. MRI CT contrast can affect your kidney function if you already have some kidney problems. MRI contrast in the presence of kidney function was thought to cause what we call a thing called NSF. It stands for nephrogenic systemic fibrosis. Skin disorder that can happen from gadolinium is the contrast we use because of deposition. But the more we learn about it, we're finding that's not, that there is decreased risk than what we usually thought. So we are able to use that contrast even with patients with kidney dysfunction now. So the contrast scanning, I would say, even in my patients who are young, I would repeat it every 3 to 4 years. And older patients more frequently, directly with contrast.
Okay. Is there any difference in quality between a regular transthoracic echo versus an office small echo machine?
Yeah. So the echo machines also come in different shapes. So there is a small probe that's called, the company that surface probes that are made, this called Butterfly. I don't know if you guys have heard of. It's a replacement for stethoscope if you ask me. It can view the heart, it can view the ascending aorta, and it connects to your iPhone and you can take a picture. We have that small to something really highly equipped echo machine. An office scanner actually is a pretty good scanner if it's as an echo machine. It should be good enough to get because the main image that is used for measuring the aorta will not be different between an office scanner and a very equipped echo machine because it's the most common image that's acquired.
Okay, great. I'm going to ask about gating again, just for some clarification. This person watching tonight said he recently had an MRA where a belt was wrapped around his midsection to measure his breathing. It seemed as though images were often taken at the end of exhaling. Is that what you mean by gating? And if so, is there a better way to gate that would produce better images?
See, exactly. So you can gate for on the MRI. I think the image he or she got is what we call respiratory gated, EKG gated navigator. What it does is we're gating for his breath hold, breathing, and at the end of exhalation is when it acquires the data and a certain time of the EKG. That's the reason it takes almost 5 to 10 minutes to acquire that image. He's right. So they're measuring his breathing here and they're making sure they acquire every time at the same time because that sensor that's on his body tells them when he's exhaled or not, and then it acquires the image. Yes, it's true.
Great.
That's a good question. Yeah, I like it.
I'm telling you, we have very educated people who are they're going to fill out a survey after this. So hopefully you're getting these right. Okay, here we go. Does CT provide additional information regarding mitral valve prolapse and regurgitation if an echocardiogram has already been done?
So the CT that's done for the thoracic aorta is a static image. So it's one phase of the heart that's acquired. So it will not show mitral valve prolapse. Okay. Echo is the better test for showing mitral valve prolapse and regurgitation, always. With CT, you can acquire that image to show, but it involves a lot more radiation. But I don't think it's the right thing to do.
Okay. Okay, somebody has recently been diagnosed with Loeys-Dietz. An MRA was recommended. Is that what you would recommend to start?
Yes,
Yes.
I would do first line as MRA of different vascular beds from all the way up to the chest to the pelvis of the aorta. Yes.
You know, we got a couple of questions in advance about looking at the thickness or thinness of the aortic wall. So can you talk about that a little bit? Like, are you looking at that with these images, the thinning of the aortic tissue, and do these different tests measure that as well?
Yeah, so that's a very good question. We can see the wall of the aorta definitely on different techniques, and the measurement of the wall thickness is very difficult. If you can think of how thin the wall is, what ends up happening is the spatial resolution, in the sense that ability to differentiate between 2 points is less. It's so thin, it becomes very tough to measure. But what do we know is when there is an aneurysm formation, the wall is thinning already. And I think if everybody, if there are physicists on the call, they recognize the wall stress increases exactly opposite of the wall thickness. It's not a direct, it's not a direct, as the radius increases, wall stress increases, but the wall thins, the wall stress increases. So we know the wall stress goes up as the aneurysm formation happens and the wall thins. But to answer their question, I don't think there is a very reliable methodology of measuring the wall thickness yet. You can measure it, but I don't think it's as reproducible yet.
Okay, thank you, because we did got a couple of questions about that in advance.
Yeah, what we can measure though is the wall stress. There are techniques which are being validated to measure the wall stress itself, which would be very good.
And this might be related or maybe not, you're the expert here, but somebody says every time I get an echo and they're post-surgery, they have a quote unquote increased gradient pressure. Can you explain what that is, why, how it affects, what's the effect of that?
They've had surgery already?
They've had surgery and they have increased gradient pressure. So what is increased gradient pressure? What are they talking about? It's from the echo. It's in the echo report.
Yeah, gradient, right?
Yes.
Yeah. So I'm assuming they've had a surgery for aortic valve and the aneurysm, a Bentel kind of surgery with a graft and the bioprosthetic valve. So that what ends up happening is natural valves they have maximum opening and produce very less gradient across that valve, in the sense that the pressure change across that valve or velocity change across that valve is less. But when you put a bioprosthetic valve, which is not an ideal valve, right? It doesn't last forever. It lasts about 10 to 15 years. There is a inherent pressure gradient across that valve. There is flow gradient across that valve that increases as the age of this bioprosthetic valve happens over a period of 10 years because of wear and tear. If it acutely happens right after the bioprosthetic valve, it's because they may have had blood clots or something on the valve, but usually the gradient increases as it gets older.
Great. All right, thank you. I'm just going through, there's so many questions that you guys are all asking you're giving me like whole stories here. It's hard for me to find the questions in your stories. Sorry, let's see. Here's another question about the integrity of the artery, which we talked about a little bit. A lot of you are asking questions about medications, when to have surgery, and that is all, and other symptoms that might be related to enlarging aorta or leaky valves. And so that in some of the fact sheets that Helene is sharing with you in the chat box. So we don't have one expert for everything here, and obviously we don't have enough time for all that. Let's take one more question here. What's the best way to image if the ultrasound can't see the aortic valve and the patient has a difficult airway for intubating? I guess for TE or something.
For the aortic valve?
Yes.
I would say it depends on if it's a leaky valve. You know, cardiac MRI, a complete cardiac MRI, not just thoracic aorta, they don't have to get intubated for that scan. It's done without intubation. As long as they can hold breath, you can get a complete valve insufficiency assessment by a cardiac MRI. That's the test I would use, yes.
Great. Is there a number for how many CT scans in a lifetime would be considered too much radiation?
We have a limit. What we use is called ALARA, as low as possible all the time. But yearly, a dosimetry is set for patients. And even the EMRs give us a yearly peak of how much radiation we can give each patient. But honestly, a yearly CT scan, I'm trying to kind of making it simple here, but with the kind of scanners we have, not a whole lot of radiation with a yearly scan or every 3 years scan, CT scan, especially if you use more advanced scanners that we are using now. You can pretty much get like a 10 X-ray worth of radiation per one scan, which is not much.
Okay, so one more good one that was short that I wanted to ask you. How much change in dimension is too much?
So my understanding is about 3 millimeters every year or less, or every 6 months, 1.5 millimeter is what I would worry about if there is change. And within that range, if it's measured the same way, you can actually make out the difference. You'd be surprised because of the spatial resolution of CT and MRA. Those changes can be easily measured.
Great. Thank you so much for answering all those questions. There are so many more, and I just wanted to address a couple of points that I see in the Q&A here. So we'll be sending out links in the email that we send out tomorrow. We'll try to include some of the links that Helene was posting today. A lot of those links will have answers to the questions that you guys were asking about medications and when to have surgery and all that kind of stuff. I'm sorry we can't spend all night with Dr. Polsani here, but he's really, what he's given us tonight's really been incredible. So before we wrap up, I have a couple of more slides that I want to share with you all. And so, as I mentioned earlier, if your questions were not answered tonight, please send them to our help center. That's Jan Lynch, the nurse in our office. And she's not actually in her office anymore. I shouldn't say that. In her home office. And she will answer your questions. Marfan.org/ask. And that's really the best and fastest way to get your answers. We have other educational opportunities coming up. Later this month, we have a COVID update on April 26th, also 7 p.m. Eastern. And we're going to be featuring a senior advisor to the White House COVID response team. She's also chair of the COVID-19 Health Equity Task Force for the current administration. That's Dr. Marcella Nunez-Smith. She's actually part of our community. She has a young daughter with Marfan. So she will be speaking that night along with Dr. Kim Eagle from University of Michigan, who's the chair of Gentac Alliance, and Dr. Enid Neptune, pulmonologist at Johns Hopkins, who's on our professional advisory board. Then in May, in conjunction with the Gentac Alliance, which as our new science arm, we're going to have a presentation on advances in treatment of aortic dissection. And that is for the broad aortic disease community. Genetically triggered aortic diseases, not just Marfan, Loeys-Dietz, but VEDS. And I know we have people on tonight with different mutations. And please, you're all welcome, and we'll be hearing about the advances in treatment from a couple of young experts from WashU in St. Louis. As Michael mentioned earlier, our 2021 annual conference is coming up. It's virtual, so you can log on from anywhere, July 8th to 11th. Medical presentations, quality of life, a lot of opportunities to connect with other people. And it's really going to be incredible. A couple of more things for connecting with communities, our Walk for Victory program, which is really popular even in this virtual world. And so you can connect with people online. We have great incentive prizes and an opportunity for scholarship and travel to our 2022 annual conference in Newport Beach, and that's the Newport Beach Marriott. And you can get involved with a walk. Go to marfan.org/walk, find one near you, join our global walk, and you can find out how you can get connected to people and win some great prizes. So before we end tonight, I want to thank Dr. Polsani again and see if you have some final words for our attendees. We had over 100 people on tonight. It's been really great.
Thank you for giving me the opportunity, and I hope I served as much as I can to help educate on the imaging aspect of it. I know it's hard to cover this topic in 30 minutes. It's very broad in terms of imaging, but thanks for giving me the opportunity.
Well, we appreciate you sharing those images and it's really showing us what's actually going on when our community members are getting these tests. Michael, any final words?
Well, first of all, thank you, Dr. Polsani. That was great. And I actually think maybe we should award everyone on this evening's broadcast with a master's degree because of their expertise and questions. I think it may be the brightest group we've had, and that was certainly the quickest and efficient answers we've had as well. So again, Dr. Polsani, great for you. Thank you for the active community we had tonight. One other mention, we had a Defy VEDS scientific meeting last Friday, and sometime later this spring, probably in May, we will have an update on science for folks that are interested as well. We'll be doing a webinar around that. That will probably be announced in the next few weeks. With that, Eileen, thanks for another wonderful job. You should have some kind of degree as well. And
My television host degree.
there you go, television host. You could be the new Maury Povich of the foundation.
Okay.
Whatever. Anyhow, everyone have a terrific night. It was great.
Thank you all
Thank
so
you.
much. Thank you, Dr. Polsani. Thank you, Michael. Have a great
Thank
night.
you.
Good night, everybody.
Good night.